and EACS. My name is Timur Nouri, and I work at the ECDC. Just to tell everybody that this webinar is being recorded, and we hope to upload it on the EACS website by tomorrow, together with all the presentations. Please make sure that your microphones are muted. We can try and help you with that later on, but please try and check that now before we get started. And if you have any technical problems, please let us know in the chat. And yes, as I said, we will be sharing the presentations following the talk. I hear a lot of background noise, so if you can try and mute yourself, that would be great. So this is the program for today's webinar. Can we please mute yourselves? Thank you very much. So we have 4 speakers today. The second one on the mpox in pregnancy, which was cancelled last time. Unfortunately, Sean just texted us and said that he had to cancel today again due to an emergency situation. So that's unfortunate. But we have 4 great speakers. The first one is on a Eurosurveillance paper that was published on the 29th of August on the Rapid Regional Mobile Laboratory Response and Genomic Monkeypox Virus Surveillance, the 7 East African Community Partner States, from Florian Guerre, who will start us off very shortly. We have another paper from the 29th of August on sex workers and the mpox response in Africa. Isaac will walk us through that interesting paper. Olivier from Grenoble University and also an ESCMID vaccine study group representative will be talking about mpox vaccine to boost or not to boost. And at the end, we have Chloe Orkin, who you all know, who will be talking a little bit about what we know about natural immunity and post-vaccine infections. So it's a great program, and I hand over to you now, Esteban, to introduce yourself. We don't hear you, Esteban.
Yeah, sorry for that. No, it's my pleasure to be with you and speakers and so distinguished audience talking again about interesting topics about mpox today. And I am Esteban Martinez. I am working in Barcelona, the University of Barcelona Hospital Clinic, and also the current president of EACS. So it's my pleasure to introduce, without further delay, our first speaker, talking about tools and in particular, rapid regional mobile laboratory response and genomic surveillance in the East African region. And speaker is Florian Guerre from the Bernard Nock Institute in Hamburg, and also working with the East African Community Secretariat in Tanzania. So it's my pleasure, Florian, please.
Thank you, everyone, and good afternoon. Let me share my presentation. See my presentation quickly, can you?
Yep. Can you enlarge it to the full screen? That's okay.
It's okay now?
Yes.
Okay, perfect. So yeah, again, good afternoon, everyone. Let me introduce myself. My name is Florian Guerre. I'm from the Bernard Nock Institute for Tropical Medicine in Hamburg, but also for the from the East African community here in Arusha in Tanzania. I'm actually in Tanzania, in Arusha at the headquarters. And I'm presenting on behalf of a large consortium, so I don't want to take all the credit here by myself. You can see all the authors, and also we published in a paper. You can then read up on that. And I'm going to talk a little bit about what we are doing here in East Africa with the EAC, with the East African community, in terms of the monkeypox outbreak that is going on. Just a very brief introduction and background. What is the EAC, the East African community? We are a regional economic community comparable to what the European Union is. We are 8 East African partner states, and these would be DRC, Congo, Tanzania, Burundi, Rwanda, Uganda, Kenya, South Sudan, and Somalia. Also, since this year, our region has around 300 million people, inhabitants, and yeah, and when it comes to outbreaks, we are basically all facing the same problems in the region. These outbreaks, they do happen in the periphery of the countries where there is no real lab capacity to diagnose. So the common practice is to basically collect samples somewhere in these remote areas and send them then to centralized labs in the capital cities mostly, or even to regional reference labs. And that basically leads to delays in patient diagnosis, sometimes days, weeks, or if the sample degrades even without any diagnostics. And this obviously is not good for an outbreak because transmission can go on and then the outbreak emerges. So we try to reverse this common practice. Instead of bringing the sample to the lab with our mobile labs, we bring the lab to the sample. By that, we basically shorten diagnosis and we block transmission earlier and hopefully contain the outbreak before it ever really emerges. I'm not sure if this slide projects properly, but I'm giving you a background now a little bit about our EAC mobile laboratory network that we established since 2017. We did this together with the original 6 partner countries at that time. We worked together with the Ministries of Health and the National Public Health Labs in Burundi, Kenya, Rwanda, South Sudan, Tanzania, and Uganda. And during a first phase, which is about to conclude, we basically handed over 9 mobile laboratories for viral hemorrhagic fevers. You can see them on this picture. They're box-based. They're basically packed up in boxes. And we trained the countries on how to use these ones. And then a second phase, which is ongoing, is we are going to procure container-based labs for AMR surveillance, but that's not really the topic of today's presentation. So I will focus on these box-based labs. And these box-based labs, you can basically set them up in any kind of infrastructure. On the picture here, you see them in a tent. Then we were taking part in a WHO field simulation exercise last year in Turkey with our East African team. And what we can do in these labs, we receive infectious samples, we have glove boxes, and then we inactivate the samples in the glove boxes. And once they are non-infectious, we can then just do conventional PCR or also ELISA if this is needed. So we can do this in the field. But mostly we do obviously PCR, especially when it comes to outbreaks. Again, I think this slide doesn't project very well, but this is basically the rapid communication that we published in Eurosurveillance if you need more details. But I'm going to tell you a little bit now more about what we're actually doing for the mpox outbreak with this network. Here again, you can see on the left side the map of Africa and our countries that are part of the EAC. And you can see that with the DRC Congo, basically, with over 5,000 cases in 2024, we have the most affected country on the continent in our community, Burundi with 385, and Uganda, Kenya, and Rwanda with 8, 5, and 4 cases so far reported by 8th of September, basically last week. We have 5 countries that are directly impacted by the outbreak or epidemic. And Tanzania, South Sudan, and Somalia, basically due to their proximity to the countries that are affected, they are at risk as well. And yeah, it's the clade 1b that is basically circulating. And because of this regional dimension, the EAC is assisting here and developed 3 key interventions that we are implementing at the moment. First one is that, as you've seen in 2017, DRC was not yet a member of the East African community, but Congo just joined 2 years ago. So now, to fast track the integration into our project, we are basically handing over a mobile lab in boxes, as you can see here on that picture. And actually yesterday at the East African community was the handover then of this lab, the symbolic handover, and it will go on its journey towards DRC in the next days. We are also donating test kits for mobile laboratories in all countries. which then leads to the second big intervention that the EAC is doing. We are providing seed funds for deployment of our existing mobile lab network, which you can see basically on the map on the right, that these labs are now in action, mostly around the DRC border regions. And in Burundi, they deployed to the Kayanza region, Uganda to Bwera, Rwanda, they split the mobile lab into 2 units, and they are in 2 districts. In South Sudan, the team is supporting the central public health lab at the moment, and DRC is planning a mission once they receive the lab, probably to deploy towards Kivu, and Kenya and Tanzania will also then deploy towards the border regions, to screen commuter populations. The pictures show you in Uganda, the lab is set up at the Bwera hospital, and in Burundi, our team in Kayanza. And the last, third big intervention that we are doing at the moment is to strengthen mpox genomic surveillance activities in the countries. For that, we gave Illumina NextSec 1000s to the centralized public health, national public health labs, so that they can do large-scale high throughput sequencing and genomic surveillance. And then we gave mobile ISAC units to our mobile labs so that they can be used in the periphery. This comes together in 2 weeks. We are in Burundi. We are going to conduct refresher trainings also for genomic surveillance, one specifically a wet lab training, and then also an mpox bioinformatics training again. And so the countries are now equipped basically with this kind of genomic surveillance capacity and network. And we hope that we can use that then for mpox, but obviously then in the future also for any other outbreak. Yeah, these are the 3 big interventions that we are doing at the moment. So let me conclude here. As you can see, our mobile labs are basically operated through the Ministries of Health and their national public health labs. We handed them over, so the countries are really operating them. That allows us to have a very rapid first-line response. We don't rely on outside direction and help anymore. In East Africa, we can basically now deploy very quickly. In the future, genomic surveillance will then be possible now for mpox, but also for other diseases and outbreaks. And when it comes to regional outbreaks, the EAC can obviously assist easily in coordination, being the regional intergovernmental body of these countries. Yeah, in general, I think this is a network that might also be of interest for other stakeholders. And yeah, let me then quickly acknowledge and wrap up this short presentation. Yeah, I want to obviously thank our funders, which is the German ministry, the BMZ, through the German Development Bank, our colleagues at BNITM in Hamburg, and then, yeah, most importantly, the EAC, East African Community, and the partner National Public Health Labs in Burundi, Kenya, Rwanda, South Sudan, Tanzania, Uganda, and the DRC that just joined our network basically. And yeah, the credit goes to them because they are basically doing the work in the field and doing a good job there. Thank you so much, and I'm happy to have questions.
Thank you, Florian, for this important initiative and quite singular that may provide so much help. So I want to promote the discussion again, asking our attendees that if anyone has a kind of question, don't be shy, please raise your hands and directly speak to Florian, or if not, if you prefer, you can also write your question in the chat. I would like to start with questions. First of all, to congratulate. This is a task of many people, many different bodies in different countries. So I can imagine that it has not been built in a few days or even in a few weeks. And probably mpox is the reason for you to be here today, but other pathogens may be also important or even more important in the next future. So my question is, when these labs, mobile labs, are available and can be mobilized, is the reason restricted to a single pathogen such as mpox in the case of obviously acute epidemics, or are you also taking the profit to address it for other potentially endemic or epidemic pathogens?
Yes, thank you. Do you want me to answer now or?
Well, yes, you can do if you wish.
Okay, yeah. So obviously, the labs were designed to respond to a lot of priority diseases in East Africa, and also the countries, the national public health use them the way they want, and they've been already used for a lot of outbreaks. They were in the region, obviously in Corona, did like screening on the borders. We were in Uganda during the Ebola or Sudan virus outbreak. We were in Tanzania with the mpox outbreak, yellow fever in South Sudan, and now mpox. But overall, the countries can use whatever they want, and they're not limited. And they are also, in theory, not necessarily limited to responding to outbreaks. Only we could also do disease surveillance with our ELISAs and also research studies if there's interest from the countries, for example.
Great, Florian. So that's an incredible initiative. I think there is a question from Binod. Please, Binod, whenever you want, you can take the lead asking the question.
Okay, thank you, colleagues, and thank you, Florian Gere. My name is Binod Mahanti. I'm working in the German Ministry of Health. So we are working closely with WHO, and my question is to Florian Gere about the coordination. How much of coordination do you see with Africa CDC or even WHO in these responses that you're providing, including the labs and the diagnostics and so on? I would be curious to understand, because we have a sense that maybe the coordination is not working too well. Thank you for that.
Okay, thank you. I think from my point of view, I think it's a little bit hard to judge from where I'm sitting here at the EAC in Arusha, because we are basically at the regional community. But as I said, the countries are really in operation through the national public health labs. So from what normally happens is that then if in case there's an Ebola outbreak, let's say in a country, then they have their own task force meetings or whatever they want to call it. And these are normally then in coordination also with the WHO and other stakeholders. So I think the coordination of national outbreak responses goes then through the ministries of health on that level and their national task forces. And for example, I've seen before or during Corona, I want to believe that a lot of funding also came from outside donors, not entirely through our project. Normally, we only gave seed funds, and then these labs continued through other pots. And I think this is also the advantage in including it or running these projects through the national public health labs, that actually they become part of the national annual budget of the National Public Health Lab or the Ministry of Health. I think this is as much as, and I can say my EAC colleagues, they are in touch with the Africa CDC also on a lot of aspects.
Great. Any probably if any additional question is available, we will have some time for it. If not, I just want again to congratulate you and all your team for this incredible project. I think it will bring a lot of support, a lot of help for the care of people in these countries, and also for the health authorities in the region. And beyond that, also a great source of knowledge on mpox and other pathogens for the whole community worldwide. So thank you very much, and congratulations, Florian. I hand over.
Yeah.
Thanks. I hand over to Timur, this is a live event, and you are aware that we are missing a speaker. Well, those things happen, and I hand over to neighbor to Timur, so you can introduce next speaker.
Thank you. Thank you so much, Esteban, and thank you again, Florian. So as I said in the beginning, for those that missed the beginning part here, the second speaker on mpox in pregnancy unfortunately cancelled last second again. So we will see if we can schedule him a third time. But we have the pleasure now to invite Isaac Olushola Ogonkola, who will be speaking on a really interesting paper that was published 2 weeks ago on sex workers and the mpox response in Africa. So Isaac, please feel free to share your screen and take the floor.
Thank you so much, Penny. Can you hear me?
We hear you, not super great. So if you can be closer to the mic, that would be great. But otherwise,
okay. Is it better now?
A little bit better.
Okay. I'll just share my screen right here.
Isaac, are you still there?
Yes, I'm trying to share my screen.
Good. Okay, perfect. If you do have challenges sharing your screen, let us know and we can share the screen. But try it yourself first.
Okay. Sorry, do you mind sharing from your end, please?
Sorry?
Do you mind sharing the screen from your end?
Yes, okay, please. Jasmine, please share the second speaker's screen.
Yeah, 1 sec. Okay. Can you see it?
See it? If you can, there we go. Perfect. So please, Isaac, go ahead.
All right, thank you so much. My name is Isaac, and I'm representing a group of 4 co-authors. We work together to write this short communication on addressing the unique vulnerabilities of sex workers in the mpox response in Africa. Please, next slide. All right, so the mpox was announced as a public health emergency of international concern recently, and one of the key things that informed our short communication, this research work, was one of our papers we published on the African continent fighting the mpox virus without weapons due to unavailability of vaccine in the country, and also for the fact that one of the new strains of mpox affects sex workers greatly in African region. The clad IB strain of monkeypox is really affecting this set of people. And so, if we are to trace it back to the endemicness of mpox in Africa since 1970, the situation has worsened so far. You could see some of the data we have there with thousands of people being affected in most African countries, including Nigeria, where I am based. Next slide, please. And so in our paper, we look at the key vulnerabilities of sex workers in Africa. And we could understand that sex workers have heightened risks due to their occupational exposure, compounded by the stigma they experience, criminalization of sex work in Africa, in most African countries, and also the limited access to healthcare that this population experience. And then many sex workers in Africa work under conditions where they lack access to preventive measures. It was very obvious during the period of COVID-19, and we are experiencing similar outcome during this mpox response. And most of them don't have access to testing facilities, testing, or vaccination. In fact, vaccination is still a mirage. Mpox vaccination is still a mirage in most African countries. And so sex workers are being marginalized when it comes to this. And also for the fact that the intersectionality of sex work with poverty, discrimination, and then criminalization of their work, like I mentioned earlier, further isolates this population from public health interventions and exacerbating mpox spread. And sex workers in Africa have interactions with a lot of people in a day. An average sex workers meet up to 5 to 10 persons in a day. And so that is a point of concern for the mpox response. And so we also look at some of the barriers to effective response. Next slide, please. Some of the barriers that sex workers face in effective mpox response. Next slide. And like I mentioned earlier, the criminalization of sex work in Africa is still a thing. And in most African countries, sex work is illegal, driving the workers underground. Illegal, a lot of people engage in healthcare services from the providers due to stigma and discrimination of workers, and also the lack of testing to treatment and vaccination. And having limited access to healthcare means that many sex workers avoid traditional healthcare facilities due to this fear of stigma and legal repercussions, because some of them have been reported to the enforcement agency, which makes things quite difficult for them to access these services. And then this results in underreporting and unchecked transmission of mpox, because there is no way to pinpoint these services for them. These services are not available to them, and so we couldn't pinpoint or report carefully the transmission of mpox among this vulnerable group. And so we also have lack of targeted interventions. There are no specific interventions targeted towards this population, and this leaves them without resources necessary for them to help themselves in terms of healthcare services and testing, vaccination, and then health education. Next slide, please. And so we have this public health recommendation to improve the mpox response for sex workers. We established that there is a need for us to prioritize sex workers in vaccination programs, especially in high-risk regions. Also, we need to understand the fact that 80% of the African populations live in rural parts, in rural Africa. And so there are needs to prioritize sex workers in the rural region as well. There's a need to develop culturally appropriate health campaigns that specifically target sex workers, providing clear information on mpox prevention and treatment. And also, we propose that it would be great to have health campaign information in diverse language, in the pidgin English across the West African countries, where most of the sex workers have limited English literacy. Also, we believe working with sex worker-led organizations to plan and execute health intervention is very, very critical. There's a need to work with them right from ideation to the implementation of diverse health interventions for them. And then we also call for the decriminalization of sex work as a public health strategy, because we believe by decriminalizing sex work, the government can bring workers out of the shadows, improving access to healthcare and reducing the mpox transmission risks among this group. Next slide, please. All right, and so we have this table that shows the key immediate intervention that could address the harms of mpox among sex workers in Africa. We categorize them into 4 different domains. We have the health services there, we have the community support, and also we have the legal and protective measures, and finally the mental health support. And so, next slide. In conclusion, we believe that the mpox outbreak presents a unique challenge for sex workers and in Africa, and we believe a coordinated and inclusive public health response to is critical. not only curb the spread of mpox, but also to address the broader health disparity faced by this unique population. And so there's a link to the full paper there and also the references and the authors. So I think I'll just end it here. Thank you.
Excellent. Thank you so much for that great talk, Olushula. Really fascinating to hear this important work. You talked a little bit, Olushula, if I may ask the first question, please raise your hands in the chat or ask some questions there if you want to. But I have a question, Olushula. You talked about, of course, working in a very difficult environment, right, with decriminalization of sex work and driving, where people, sex workers are driven underground, etc., and the importance of vaccinations. Have you seen vaccinations reaching out to this population already, or is this something that you're struggling with? And do you encounter difficulties in getting access now that the vaccinations are being distributed?
Well, for vaccination, it's proving very difficult to get vaccination across to this population because the African continent is still struggling to have excess of vaccination for the general population, and most of the vaccine programs we have in most African countries now is at healthcare facilities, and most of this group of sex workers find it difficult to access healthcare facilities to access some of these vaccination. And that is one of the reasons we propose there could be some mobile health services that could reach out to sex workers in places where they are, like because we believe putting in people first instead of having the how to reach people. I think we can look at it from the angle of how to reach services. If these services like vaccination can be taken to them, that could address the challenges of vaccination among sex workers. Thank you.
Thank you so much. Just one more question before I hand over to Esteban. Do you know if there is a keen interest among the population to get vaccinated?
Please, your question again, please.
So do you think there is a demand among the sex workers to get vaccinated? Is there awareness of what's going on? And do you think there is a demand if vaccinations were available?
Well, the health education on monkeypox is still very low, and not so many people are aware of what is happening. And also for the fact that most information are present on social media, on television, and this group of people don't have access to this means of communication. And so the spread of health education on monkeypox is still quite low in most African countries. And I think that shows one of the lapses we need to fill with our education, engaging community health workers to go to this population and talk to them about the current pandemic of mpox in the countries.
Fantastic. Thank you so much. Esteban, please.
Yeah, you ask Taimur. I congratulate also Isaac for your nice presentation. And Taimur raised a topic that is very important, and I think it's awareness of sex workers about the potential pathogens that now mpox, but others that may be exposed to, and also although the getting support from the outside may be difficult, with your experience, again, it's not only awareness, but also the ability to organize. I mean, can they get a face or a body to represent themselves, and then to make themselves be listening by authorities or by other societies or governments or whatever. So my question is, do you think that at least being aware of this, are they able to organize themselves in preparedness for the short future or for other epidemics?
Yeah, thank you so much, Esteban. That is a very good question. There are network and association of sex workers. There are coalitions of sex workers group across different African countries. And I think that is one of the key strengths governments and key stakeholders could explore to get health education on mpox across to them. And with leveraging such coalitions or group, we could have a lot of interventions spread across to this key population. But the only challenge could be that most of these coalitions and groups are usually in the urban region in African countries. And so it may be difficult to reach out to sex workers who are in rural Africa. And so we may need a different strategy to address those ones. Thank you.
No, maybe Isaac, you have to contact Florian, and at least in the region where Florian and his team work, to get the benefit of the mobile network that they have, so the positive response can be boosted and improved. So that's a suggestion. Well,
Thank you so much.
Thanks, Isaac. I hand over to Taimur.
No, thank you so much. Excellent, excellent presentation, and really fascinating to hear these the challenges that you're facing. And yes, I think if there's no other questions in the chat, and I see nothing and no hands up, Esteban, let's move on to the next one. Go over to you, Esteban.
Yeah, thank you, and Taimur. Not only a new presenter, but also a new topic, very important, and it's about the field of vaccination. And again, some people has received the vaccines for mpox in the recent past, in the recent years, because of the recent epidemics. But we are confronted to a potential new epidemics. There is epidemics in Africa too. So what about mpox vaccine, and particularly the MVA mpox vaccine, to boost or not to boost? And Oliver Poulard from the Infectious Diseases Department at the Grenoble University will be talking about this topic. So thank you very much, Olivier. Now it's your turn.
Thank you very much, Esteban. Can you hear me?
Yes, perfectly.
Okay, so I would like to thank the ECDC and the ECDC to have accepted indeed that we may share with everybody the arguments that may lead to choose to recommend a boost for the MVA vaccine for the mpox. I have no conflict of interest to declare, apart from being a part of the NITAG, of the French NITAG, that had recently recommended 2 weeks ago or 1 week ago to do a boost in 2024 for the people vaccinated in 2022. And I would like to share indeed the reflections that may come from various fields, the data from non-human primate, the data from breakthrough infections in human, the immunogenicity data in human, and the past and maybe the future of the epidemiology of mpox that may lead to recommend a boost. First, the data from the non-human primate models. As you know, MVA has been used for decades now as a vector vaccine, as a vector to vaccinate, in particular against HIV in a non-human primate model. And some studies have taken advantage of this to test the immunogenicity and the efficacy of MVA, not for the HIV, but for the mpox itself. And for example, in this study, the cynomolgus macaque have received 2 doses of MVA, and then 3 years after, the authors choose to do a challenge, an intravenous challenge, a high intravenous challenge. So it is a long time, 3 years after the primary vaccination. And they observed that most of the monkey in the vaccinate group, the first 4 lines, have some viremia, and also that they have a lot of skin lesions. They were protected against death compared with the control animal, but they developed the disease. And it was a bit the same thing with other study, also taking advantage of having used MVA as a vector, but to explore the efficacy as an anti-mpox vaccine. And more than 2 years after the primary vaccination by 2 doses, they have also done an IV challenge of mpox virus in the non-human primate. And they also observed that there was a viremia in this monkey, in this macaque. It was lower than with naive, the control animal, but it was there. And some of the macaque also display some skin lesions. So the long-term immunity in this model is not totally efficient to prevent the infection. It may prevent severe cases, but not cases. Other argument may come from the observation of breakthrough infections. Recently, a nice meta-analysis was published regarding the efficacy of the mpox vaccine of the MVA vaccine for mpox, reaching 81% efficacy. And it is different probably according to the time period that you are considering. For example, in the Spanish study, there were virtually no cases in the first 5 months post-vaccination. But if you look at other studies with a longer period of observation, for example, in this study reporting an outbreak in Chicago, they observe a little outbreak of nearly 50 cases. The majority of the cases were fully vaccinated, 2 doses. And what is interesting is that there were a median time of 9 months between the last vaccination and the disease, suggesting that maybe there is a decrease of the vaccine efficacy a long time. And this was also suggested by this recent paper from the ECDC, displaying the cases of mpox according to the vaccine status, pale blue not vaccinated and dark blue vaccinated. And you observe the same thing. The case may occur far or several months after the vaccine campaign. And the author reporting that the median between the last vaccine dose and the infection was 266 days. And very interestingly, it was longer after intradermal vaccination compared with subcutaneous vaccination, which may suggest that the 2 vaccinations have not the same efficacy, but that the 2 vaccinations may decrease in efficacy after some months. This is also supported maybe by some data regarding the immunogenicity and the months after vaccination in humans. For example, this poster presented in Barcelona in the ECMID reported that the titer of neutralizing antibody in people who had never been vaccinated, it is a blue box. People never vaccinated, for example, not vaccinated as a child before 1980. 3 months after the second vaccination, the decrease of the neutralizing titer was important. And this was also reported, for example, in this medRxiv manuscript. 1 year after the last vaccine dose, the titer of neutralizing antibody is low. And this was also reported by this last year paper, looking at the long-term immunogenicity of the MVA in human, and observing that they were comparing the old vaccine with the MVA, and they observed that either in neutralizing titer or ELISA antibody concentration, there was a decrease of the antibody a long time with the MVA. And when they perform the boost, they observe a high response, and most interestingly, a persistent response after the boost, as if the boost was allowing the immune system to maintain a high level of immunity a long time without the decrease observed after just the 2 doses of the primary vaccination. And they also observed that the number of people seropositive for neutralizing antibody was higher and persistent after the boost. And in addition, there was this nice theoretical paper regarding the predictive effectiveness of mpox vaccine, and suggesting that the higher and the more persistent immunity could be obtained either by doing 2 doses separated by 2 years, but with this system you do not protect well people during the first period, or with 3 doses, 2 doses of primary vaccination, and then a boost after 2 years. And at last, if we look at the past and the current mpox epidemiology, mainly in Africa, we observe that, for example, in this study, that the number of country reporting cases is increasing a long time in the last 2 decades, with a number of cases which were increasing in the last 2 decades. And of course, as this has been reminded sooner, by a previous speaker, there is now this big outbreak, mainly in the Democratic Republic of the Congo, suggesting that this trajectory of epidemic a long time will still develop in the coming decades, and we will still face outbreak, mainly in Africa, in the coming decade. But we will face probably not a lot of immune variation from these viruses. In opposition, for example, with SARS-CoV-2, we do not expect, given the relatively limited genetic diversity that is displayed in the last 20 years, we do not expect to have some immune escape variants of the mpox. This was not observed with smallpox, and it is rather unlikely to occur with mpox. So if we summarize, the breakthrough infection mainly occur after 6 to 9 months. The neutralizing antibody titer decrease after 3 months, and there is an increase and a persistent increase after a boost. In the animal model, the long-term protection is not good after primary vaccination of 2 doses, and we are likely to observe outbreak in the coming decades. And therefore, it is important to establish a long-term immunity in the European exposed population, not only European, of course. And this is why the French NITAG shows this very disputable, and we are open to discussion, recommendation to recommend the MVA boost after 2 years for the people non-immune before 2022. We have received 1 or 2 doses in 2022. We do not recommend boost for those vaccinated before 1980 and who have received a dose in 2022. And our objective is to prevent maximum the monkeypox virus circulation. This may be a different goal compared with other countries, mainly countries where there is an animal reservoir. In these countries, the main goal would be to prevent severe infections. But we may choose in some other countries, including Europe, territories, including Europe, to prevent any cases of mpox or any circulation of mpox virus. I may remind that the population targeted by vaccination as in other countries are the MSM with several partners, the same with transsexual persons, sex workers, professionals in sex-dedicated facilities, such as sauna, for example, and some travelers with some profiles, particularly those working in the health facility in the territory concerned by outbreaks, all those visiting friends or relatives in the same areas. And I would like to thank my colleague from the French NITAG, particularly Anne-Claude and Jean-Daniel, for the very meaningful discussions. Thank you.
Thanks so much, Olivier. A lot of unknowns still, but also a huge development of knowledge on this regard. It's clear that boosting is necessary to enhance response and to make it more persistent. Certainly, that's general for other vaccines too. And here you have outlined a clear picture of what's behind. So I again ask our colleagues in the audience, please ask your questions and raise your hands. There is a hand I can see.
And I would be very interesting, in particular, to have argument on the reverse decision that can be totally, of course, relevant, not to choose to boost.
Yeah, certainly. There is no one size fit all or 100% or zero. So, Jens, very happy to see you. And please, you have the first question, and then Chloe.
Wonderful. Thank you. Thank you, Esteban, and thank you, Olivier, for the talk. My question relates to your feelings around protective immunity and which antibody levels provide protective immunity, because I appreciate the argument about boosting, and I think they are very likely relevant, but it would be nice to try to have a better understanding of protective immunity so we have a guiding understanding. And also in relation to that, although I appreciate the genetic diversity of the virus is fairly limited, and therefore we're assuming cross immunity regardless of clade, whether you could speak to that just a little bit more. Thank you.
Your first question revolves around the concept of correlates of protection for mpox. And as far as I know, there is no such correlate of protection for mpox. Probably that it is not the same level of protection regarding an infection acquired by the respiratory rate, which is probably rather limited, or an acquisition by the skin or the mucosa direct contact, as we have mainly observed out of Africa as a sexually transmitted infection. And probably that the antibody level to protect against or the T lymphocyte level to protect against skin infection or skin transmitted infection is not the same as for the respiratory route infection. So this is one of piece of the puzzle that is lacking indeed. It would be very easy to have a threshold and to declare, okay, after this threshold, we would boost. And in addition, you may consider that the people with a low level of antibody will be protected by the anamnestic response. You have a low level of antibody, but during the time of the infection, your immune memory will come back and will eliminate the pathogen before you are ill. But given the relatively short incubation period, less than 10 days, that we observe with mpox infection currently out of Europe in the last 2 years, I'm not sure that the anamnestic response will win the race confronted with the infection if the neutralizing antibodies titer are very low. But I have no more precise response to this. And I have already forgotten your second question, which was the second question.
Cross immunity, the likelihood there's cross immunity given that the antigen drift is fairly limited.
As it is something that have not been observed with smallpox, And we are using a vaccine. So we are using orthopox virus different from the mpox to vaccinate against mpox. Even if there is some evolution within the mpox sequence, I don't think that the evolution inside the mpox sequence will be greater than the difference between vaccinia virus and mpox virus. So I would be surprised, but I am not at all a virologist, but I would be surprised to read some report of immune escape. I don't know if others in the audience have some insight on this question.
Well, thanks, Olivier. Maybe with next questions,
Yes.
there will be some information about this. I think Chloe is the next one. If not, forgive me, but Chloe, please go ahead.
Thanks so much, Esteban. So I think the question I want to ask is, thank you for that great talk. I learned a lot. What about HIV? So what should we be doing for people who are well with HIV, and what should we be doing with people with immunosuppression? If you're saying that boosting is important, when would you boost? What would you advise? Is there advice from NITAG on that?
For the people living with HIV, we have, of course, proposed to vaccinate them if their lifestyle were making them vulnerable to the mpox infection. Those with more than 200 CD4 T lymphocytes should receive 2 doses as a primary vaccination, and those with CD4 count lower than 200 should receive 3 doses. And the boost recommendation that we have emitted is for both populations, either immunocompromised or immunocompetent population. One part of your question that is also interesting is whether we should do this boost earlier for those immunocompromised. If we had some correlates of protection, it would be more comfortable to follow up, for example, the neutralizing antibody titer, as we do for hepatitis B, and saying, okay, you are lower than the threshold, so we will do you a boost. But given the efficacy of the vaccine and the fact that what we are planning is not to protect more people after 1 year, but is to protect more people, protect people for the lifetime, I'm not sure it is needed to have a shorter boosting interval in the immunocompromised individuals.
Thanks very much for that. So I think that the next question is from Kerry. Are you there, Kerry? Sorry, Kerry.
Yeah, I think she put her hand down, Corey Johansson.
Oh,
so
okay.
we can go on to the next one.
Oh,
yeah,
sorry.
Albert.
Okay. So Albert Bollard.
Yes, hello. Thank you, Olivier, for your explanation. We are discussing this also in the Dutch public health authorities. So I have a few questions about the process. You would have discussed this at length also in France, but there are very few recommendations for vaccinations to stop circulation of a pathogen. So we have, if you see the ECDC data, the mortality rate of mpox is extremely low. It's 0.035. So there is hardly any need to vaccinate to prevent severe infections or mortality. And now you make a new suggestion that you want to do it, boosting for stopping circulation. You know, from a public health perspective, it's much better to increase the uptake of the first 2 vaccines than to boost. So we had a relatively low uptake, about 50% of eligible persons of the MSM population were vaccinated. So that is one aspect. And so what I see in a lot of this reinfection or breakthrough infections, that people have a relatively even more milder disease than the primary cases, right?
Yes.
So what will happen, like you say, you don't have skin memory cells that are so sufficient to prevent you from reinfection the way that it's transmitted by tough physical contact with open lesions. So what will happen? You will have reinfections even after the 3rd dose or the 4th dose. So what will you do? Will you keep boosting them every 2 years? So and because these antibodies will always wane, and then so it is difficult to look at the consequences. I think if you had seen animal studies where they did 3 doses and then even after 3 doses they would see skin lesions, then I would believe your view. But because we could write the articles, if the authors of these articles, if they still have these animals, and give them a 3rd dose and then re-expose them to this very high level of intravenous or intramuscular doses of mpox. But you know, I have some difficulty, but we could talk about it later also in another. But I have difficulty to understand a public health approach of attacking a virus of circulating by boosting people who have waning antibodies, because they, after vaccination, we mostly see waning antibodies. But that's my.
There is so many questions that it's not easy to begin with. But first, even if we want to protect against severe infection, you can consider that having a very painful infection, even if it's not lethal, having a painful infection is prevent this kind of pain is per se a legitimate objective. The other thing is not to test people every years, and each time the antibody is waning, you give them a boost. The idea is more to do something like, for example, HPV or hepatitis A or hepatitis B, when you first have a primary vaccination of 1 or 2 doses, and then after 6 months or 1 year or 2 years, you do a boost, and after you are protected for life. This is more comfortable with infection with a long incubation, such as viral hepatitis, because with the anamnestic response, people are protected even if you have a low detectable immune agent in the blood. In addition, I think that we may obtain to prevent the circulation of the virus. First, because most of the cases are symptomatic. In the study regarding the samples in asymptomatic people, very few of them were positive, maybe 10% or not more, or less. So most of the people with disease may identify themselves as contagious. I think this has greatly participated in the control of the infection of the epidemics out of Europe 2 years ago. And having a disease which can be easily identified with a low level of asymptomatic contagious people. And 2, having a vaccine that may prevent most of the infection, even if not all the infection, the 2 combined makes the goal of having a very low or no circulation of the virus in the population, in my opinion, quite rational. And the other idea is to have this not only for 1 year or 2 years, but for a very long period, which is an argument to this late boost. But I agree with most of the arguments I have to say, even if I think that they can be discussed. They are very relevant, and we have, of course, discussed them with NITAG before taking the decision.
Thanks, Olivier, and also Albert. There is a lot here. So we have 3 further questions, and we will try to accommodate them into the next 5 minutes. So Eric, without any further delay, short question, probably short answer, if possible.
I will try to keep it very brief. But thank you for a very interesting talk, and we're obviously very interested to see the outcome of your booster doses. In Sweden, we haven't decided on a booster dose yet. My problem with the vaccine effect and the decision on booster is that it's difficult to say that the breakthrough infections are coming at a specific time point due to the uneven spread. The exposure is not consistent over time.
Yes.
We have seen a number of breakthrough infections this spring, but then we saw many more infections among naive people, and we have seen 0 infections before that. And that's a question whether we actually had any exposure in the meantime or not. And my question then is, are you planning to do sort of a real follow-up with naive persons, people who have taken 1 to 2 doses in 2022, and people who have taken a booster dose now, to see whether you actually obtain any real difference in vaccine, in protection against infection? Because I don't really see that we have that answer as of yet.
I think we plan to do the reverse. Each time you have a case, you observe whether it was naive or primary vaccinated or boosted, rather than to follow up any people with 1 or 2 or 3 doses. In 2023, there were 50 cases in France. In 2022, 5,000. In 2023, 50. And since the beginning of the year 2024, 126. So it is a very low level of circulation. And we will not do a surveillance of the vaccinated people. We will rather do, like of the country, I guess, an exploration of the cases to determine whether they receive or not a boost or primary vaccination. I'm not sure that we will obtain all the data that we would like to obtain to validate the boosting strategy. And just something to add to Albert also, recommending to do the boost does not mean recommending to stop trying to reach the people that we failed to reach in the previous year. It was quite easy to reach the MSM population, but we have still a lot of sex workers to vaccinate, for example. And we do not stop vaccinating them to do the boost.
Thanks. Well, thanks, Olivier. And for the sake of time, I ask for apologies to Valentina and Daniel, but please keep your questions alive, because we will hand over to Chloe. Otherwise, we will not have time. And at the end, I think there are many questions. Probably if this topic is quite controversial, we can come again with it. So
yes.
Sorry to
a second episode. Yes.
Yeah, and thank you, Olivier, for that. Apologies to the people still waiting. And Chloe, I hand over to you.
Yeah, just before Chloe, please keep your hands up, because there may be time towards the end, and we want to get back to your questions, and Chloe may answer some of these issues. So please don't leave, and Olivier, if you have time, please remain until the end, because I think we have time towards the end. So Chloe, over to you. We don't hear you if you are speaking.
Sorry, there we go. It's only about 4 years, but anyway, finally got it. I was asked to talk a little bit about the SHARE collaborative and sort of the work that we've, to summarize the work that we've done during the mpox response to start with. So I think just to summarize, we're an East London based sort of infectious disease group who are very focused on health equity. And we were involved in various case series, the first one being the large 528 person series from 16 countries, and then subsequently a series in women, and then a global series in advanced disease. And in each of these, we collaborated with colleagues from many different countries. And then finally, there was a case series on reinfections and post-vaccine infections, and that's what I've been asked to focus on today. We've also been working with the World Health Organization, and we've been given commissions to deliver some qualitative research on experiences of vaccination. And we've recently published a systematic review on this together with the World Health Organization, and are also publishing around tecovirimat and how people feel about receiving medications that are licensed under the animal rule. We worked with communities to develop a community survey in the UK to understand public perceptions of the media representations of mpox, and also around the experiences of public health messaging, and how we could move from messaging to interventions. We worked there with the Love Tank CIC particularly. And we also have done a global healthcare provider survey, which I'm sure many of you will have collaborated with, either filled it in or as co-authors, and hopefully that's been submitted, and we're hoping to hear back from the editors. So this collaboration came about through reaching out to research networks, long-standing HIV research networks at the time when mpox was still called monkeypox, in early May. And this was the first paper. And I wanted to really focus, before I start, on the reinfection paper, which is what I was asked to do, to remind everybody. We've just heard about waning immunity, but really to think about people with advanced HIV infection. And this was this series which looked at 382 people with CD4 counts less than 350. And about 50% of them had CD4 counts less than 200. And 1 in 5 had CD4 counts less than 100. And half of them were not on effective treatment. And what we showed is very severe and disseminated forms of MPXV, with complications affecting a range of organs, including a sort of pulmonary nodules. And unfortunately, we had mortality rates of 15% under CD4 counts of 200, and 30% in the most immunocompromised people with CD4 counts less than 100. And the ECDC have classified this as have mentioned this as an opportunistic infection now in the guidelines, and I just think it's extremely important. We've also found that IRIS did occur, and this has been confirmed by other people. So I think it's really important to recognize that we do need to take this very seriously in people with advanced HIV, and we need to bear in mind the studies that are now coming out that Olivier has so excellently presented, but also other research that's coming from particularly my colleague, Professor Andrea Antonori, his group with Valentina Mazzotti. They've done a lot of seminal research in this area, also focusing on people living with HIV. So I think this is something to focus on. So I was asked to present for 7 minutes, so I'm going to present for 7 minutes on this paper on mpox in people with past infection or a complete vaccination course. And this was co-led by me and Anu Hazra from Chicago and several other co-authors. We used the severity score that was developed by the second author, Jason Zucker, to assess severity of mpox, and that was developed subsequent to the original case series. So we basically defined, we created some case definitions. We defined a confirmed mpox case after infection as clinically suspected mpox and PCR confirmation in a specimen from any anatomical site with documented history of past PCR confirmed infection and subsequent clinical recovery. And we described a confirmed mpox case after vaccination as clinically suspected mpox plus PCR confirmed mpox infection in a specimen from any anatomical site at least 14 days after documented receipt of 2 doses of MVA-BVN administered after May 2022, and they were appropriately spaced doses. The exclusions were if we couldn't confirm the vaccination status, or in people with partial immunization, or any doses received before the current multinational mpox outbreak. So we used structured case report spreadsheets, and we used the mpox severity score developed by Jason Zucker to grade the severity. And we had 8 mpox infections after an initial infection, and we had 30 infections post-vaccination that occurred between May the 11th and June the 30th across 9 countries and 2 WHO regions. And one person, very unfortunately, had an infection that met the criteria for both reinfection and infection after vaccination. So our results showed that in reinfections, that the median duration between the first and the second mpox infection was 112 days. So this kind of fits with what's been presented. And for post-vaccination, the median was 42 days between doses, and 14 had received both doses subcutaneously. And the median time between completion of vaccination and infection was 219 days. So you can see the IQR 153 to 254, the range of 49 to 315. So this very much concurs with what's been presented. 3 individuals in the post-vaccination infection group had also received a childhood smallpox vaccination. So that's important. In terms of the people that we described, 37 were cisgendered white GBMSM. There were 37 people and there were 38 infections because of this one person. The median age was 36, and 95% reported inconsistent or no condom use. There were three cases which were related to chemsex, and 8 individuals were people living with HIV. All were virologically suppressed with a median CD4 count of 555 and a median nadir of 355.
Chloe, just to say, we lost your slides. I don't know why. They just stopped off. Yeah.
Okay. Let me share again. Can you see?
No, not yet.
Not yet.
Now?
Yeah, it's coming now. Yeah, perfect.
That was very weird. So thanks for telling me. So basically, as I said, there were 8 people living with HIV, and then of those people who weren't living with HIV, 83% were on PrEP. So that's not 100%, should have been 100, but a lot of people were receiving PrEP. And around a third had at least one STI at mpox diagnosis. So what we found in terms of natural immunity clinically is that it was a shorter disease course with less mucosal disease, just like the monkeys, than with the initial infection, so just like the non-human primate study that was presented earlier. Median mpox severity score decreased between the first infection from 7 to 5.5 in the second infection. So we were able to grade the first infection and the second infection. And the median score for active lesion burden remained the same. So that's also consistent with the non-human primate studies. The extent of body involvement, number of mucosal surfaces affected, and analgesia requirements decreased. In terms of the post-vaccination infections, few lesions, little mucosal disease, minimal analgesia requirements, and 2 people received oral tecovirimat. Overall, there were no deaths, no bacterial superinfections, and all were managed in clinic except for one person with a necrotizing skin lesion. So that's quite different from what we have seen. I thought it would be worth showing this person, unfortunately, who had a vaccine, subcutaneous vaccine on day 0, and then on day 32 received a second dose subcutaneously. And then 4 days later, developed perianal and anal pustular lesions and a lesion on the hand. The MPXV was detected, and chlamydia was detected. And continued, was receiving PrEP, had another episode of chlamydia on day 270, and on day 290 reported an mpox exposure via sexual contact, and by day 302, so 12 days later, had a positive lesion from a positive PCR from a perianal lesion. And this all resolved by day 309. So that's quite a story, really. And I just wanted to draw your attention, I mentioned them earlier, but I'd just like to draw your attention to this work from the Antonori group and Valentina Mazzotta on immunogenicity and reactogenicity of MVA-BVN. I didn't present it, I offered to summarize some of the vaccine data, but I think it is important to look at this work. They are doing sort of longitudinal work in the context of HIV. So I certainly recommend them for future webinars. So I've hopefully stopped sharing my screen. And I think I would also just want to say thank you to everyone who's collaborated within the ShareNet mpox collaborative. It's been hugely appreciated, and I've made many friends, lifelong friends through the collaboration.
Excellent. Thank you so much, Chloe, for this excellent presentation. And definitely, thanks for that recommendation. We definitely invite, was it Valentina, that last paper you recommended?
Yeah.
Yeah,
they published a few actually, and Andrea Antonori is the senior author.
Yeah, and I think both of them are on this chat, if I saw names correctly. So we'll definitely invite you to future talks. Yeah, go on, Esteban.
No, I just want to say that Valentina indeed was one of the persons willing to ask a question. And apologies again, Valentina, and also Jean-Daniel Lelivre. You can proceed with your questions if you still wish to do so.
Yeah. Okay, thank you. My question was that the conclusion about the need of a boost was based only on neutralizing antibody levels after 1 year from vaccination. But what do you think about cellular T-cell immunity and the importance of T-cell immunity? Because we saw in our work, but there are many papers published in which cellular immunity elicited by MVA-BN is very strong, is important. So what do you think about it?
Yes, I can only agree on the fact that the T-cell response is important for the mpox or for the orthopox infection, and particularly I think for the infection through the mucosa and the skin. I'm not sure that the neutralizing antibody plays such a part when the virus is transmitted through a vesicle to a breach in the mucosa or in the skin. So I did not produce there the results of some study regarding the decrease of the in the T-cell immune response after vaccination, but the trend was the same as that with humoral vaccination, and may also conduct to propose one boost, just one boost, for the same reason. But again, without any certain correlate of protection, it's not easy to discuss these things.
Yeah. Thanks, Olivier, and also Valentina for your question. I think Jean-Daniel Lelivre, so if you wish to ask.
Yes, I'm not going to ask a question to Olivier because I am one of the experts that made the recommendation regarding the booster dose in France. So maybe I can add some additional comment to those raised by Olivier. The first one regarding the last comment. Obviously, T-cells are also important for protection against orthopox virus and for mpox in particular. We have been working in my lab in the Vaccine Research Institute for many years with the MVA vaccine, and we have demonstrated that additional boosting, especially in the the animal monkeys clearly increase the T cell response, the diversity, the ability of the T cell, for instance, to produce different kind of cytokines. You know, usually after 1 or 2 vaccination, T cells are going to produce namely and only, for instance, interferon gamma. And after 1 or 2 boosts of vaccine, you may have more important and broad response, both in terms of production of cytokines, but also in terms of response to different epitopes of the vaccine. So it's quite important. And it's also important for the B cells response. So regarding I think because it's quite an important discussion to know if we need to have an additional boost for mpox vaccination. And obviously, we have no definitive epidemiological data, but there is a clear rationale for optimizing protection in the target population likely to spread the infection in our territory, at least in France. If this population were too large, which is not the case right now, the relevance of this booster dose will be obviously clearly reduced. And I think one problem, if I can say so, it's not the fact that you need to have a boost, but it's to allow the B cell memory to take place. And if you look, for instance, a recent paper, you can see that if you wait 2 years between the first and the 2 doses, you will have the same result as you perform 2 doses initially and then a booster dose after 2 years, meaning that you don't need at the beginning to perform these 2 doses. These 2 doses is only for a very short protection, but for a long protection, you need to wait and perform a new boost of the vaccine. And what will be the impact of this additional boost? It's to increase the level of the antibody present in the serum. We don't know exactly what are the mucosal response with MVA right now, but you know, and it's all the results we obtained, for instance, with COVID-19. You know that with the mRNA vaccine, you're not going to induce a mucosal response, but you will have a passive diffusion of the antibody at the mucosal level. Therefore, the more you have antibodies in the serum, the more you will have antibodies at the mucosal surfaces. And clearly, the point here is to try to block the replication and the diffusion of the virus in the target population. And obviously, mortality and morbidity remain low in this population, but one of the fear is that it will spread outside the population, and in particular in very immunosuppressed populations, such as people suffering from cancer or receiving immunosuppressive for kidney graft and so on. And lastly, to make also an additional comment regarding the animal models, we know that the current animal models are not the good one because they are challenged intravenously, and which is not obviously the best way to mimic what happens with mpox. We have Roger Legrand in France, Roger Legrand, which is one of the French specialists in animal models for several infectious diseases, has performed new animal models with rectal challenges of mpox, and you'd have completely different kind of viral kinetics. And he showed us that even after vaccination, you may have some residual viral replication and then maybe some transmission. So once again, the idea, the aim of this additional boost is not to protect at the individual level, but to try to block as more as possible the transmission within and outside the target population, which is currently defined in our countries.
Thanks so much. So just a comment, Taimur, before probably closing. If you have the link to the French guidelines, although it may be in French, that would be very appreciated if you can put it out in the chat so people can review that, and that will be very helpful. So I hand over to Taimur, please, for closure.
Yeah. Thank you, Esteban, and thank you everybody for a fantastic session today. It makes me think, Chloe, was it in 2022 when we had the outbreak in Europe, we had this great debate between you and Alexandra on whether mpox was an STI or not. And maybe it's time to have a debate next time really about the booster and have somebody who speaks for it and allow like an hour and a half with arguments for and against. And we can invite a couple of speakers. And Olivier, if you think that's a good idea, it would be great to get some suggestions for you for that kind of debate instead of presentations. We have because there seem to be a lot of questions and a lot of need for discussion. So I'd love to pick that up, and we'll discuss that with Esteban following this call. But time has passed now. I see you posted the link in the chat. I don't know if that's going to disappear now when I close the chat, but if so, I'll put the link into the notes of the meeting that will circulate and put the link there for everyone to see. And
maybe Taimur, this kind of recommendations from booster and also probably the correlates of immunity are so important topics and so debatable that we will need another webinar to discuss.
Yes, just this issue, exactly. So yes, we will share the slides and a link of the whole recording will be shared with you tomorrow. And then Esteban, I and Sanjay will meet on Friday to discuss when the next webinar will happen. But we'll bring this suggestion up for a debate instead. So thank you all very much, and we look forward to seeing you again.
And our speakers, you have been fantastic. Thank you so much. Thanks so much.
Thank you so much. Bye, everyone.
Bye-bye.
And thanks, Chloe, for the tweet. It's amazing.
And thanks.
Thanks, Olivia.
Thank you. Bye-bye.
Bye-bye.